Good morning, everybody, and welcome to the National Symposium in Neuro Ophthalmology. We're thankful to the scientific committee for giving us this opportunity. May I invite, while the previous session is just getting wound up, may I invite Dr. Navin Jaikumar to chair the session? Sir? May I also have Dr. Kumudini Sharma, Dr. Ramesh K. Kunaya, and Dr. Ambika on stage, please. May I have Dr. Kumudini Sharma? We also have an expert panel of Dr. Sujata Guha, Dr. Ambasita Anita, Dr. Varshini Shrikant, and Murlidhar. Can you be on the front row? Our first talk is going to be by Dr. Shikha Basi on OCT in Neuro Ophthalmology. Dr. Shikha is here? Dr. Shikha? Dr. Shikha Basi?
Yes. It's not connected. Good morning, everyone. At the outset, I would like to thank Dr. Rashmin for giving me this opportunity to talk about optical coherence tomography in neuro-ophthalmology. So if you do a PubMed search query of OCT in neurology, you'll have some 2,358 articles. We started with one article in 1993, and in 2023, we already have 125 publications. So what does it mean? It means that OCT has been acknowledged as a tool by the neurologists. This technology was developed in MIT in United States in 1990, and it's very similar to obtaining images with ultrasound B-scan. But instead of the ultrasound, OCT is based on low coherence interferometry, typically employing infrared light. So basically, you get the cross sections of the anterior and posterior segment of the eye. It's a non-invasive and non-contact technology. This technology it has a potential to become a disruptive technology if only we could reduce the cost and make it available for the masses, make it more portable without compromising on the quality, and if only it did not require an expertise to capture the images. This technology, though was developed in 1990, it came into the clinical practice with the development of time domain OCT in 2002, which uses 810 nanometer wavelength light, but the speed was less. It was like 400 A scans per second, and the resolution was also less, 10 microns, and we could reach till RPE. With spectral domain OCT, which developed in 2006, the wavelength of light that is used is 840 nanometers, and the speed improved to 1,000 scans per second, and the resolution also improved to 5 microns, could reach till choroidal EDI mode. Of late, we have SwepSource OCT, which was developed in 2012, and we can get the speed is improved to 4 lakh A scans per second, and with a good resolution too. So, as I said, that it is being right now used as a research tool in neurology. It has been recognized as that, and there are a lot of publications coming. So, to bring about like some standard, to set a standard in this, they have published, the neurologists have published this apostle recommendations, where they've described 9 things that should be, a person should be aware of if you're using this technology to do some research. So we shall be talking about 3 of these, that is the acquisition devices, scanning protocol, nomenclature, etc., that is used. So you have to, if you're publishing, then you have to specify these things, because it matters. The results may differ depending on what you have used. Now, these are the acquisition devices. There are a number of devices available. These are a few devices that are available at Netralaya. So there, at Shankar Netralaya, we have, and these are most commonly used devices, that is Cirrus HD-OCT by Carl Zeiss, then Spectralis by Heidelberg. And in Swepsos, the advantage is that you get a wide field scan where you can look at the entire posterior pole in one go. You can look at the macula and the optic disc in one go. And you also have devices by Topcon and OptiView. Now, in the nomenclature, this is more important for the neurologists. Most of the ophthalmologists are already aware of all the retinal layers, the short forms of the retinal layers. TRT here is the total retinal thickness. Now, coming to the topic of OCT, neuro-ophthalmology, what we need to know is basically the health of the optic nerve head. So that can be assessed using retinal nerve fiber layer thickness analysis, which tells us about the RNFL health, and the GCC health can be assessed by the macular ganglion cell inner plexiform layer thickness analysis. So on the EDI OCT, you can see, you can literally look at the, it's like an ultrasound B scan of the optic nerve head, where you can reach up to, right up to the lamina cribrosa. So what are the protocols? Now, to get the peripapillary retinal nerve fiber layer thickness, you need to get a circular cross-sectional retina scan obtained around 3.4 to 3.5 millimeter, which is centered around the optic nerve head. Now, in Cirrus, on Spectralis, it looks like this. You get the averages in 4 quadrants. And in Cirrus, the low one is in Cirrus. And basically, in Cirrus machine, you use 6 millimeter into 6 millimeter data cube, which is captured by optic disc cube 200 into 200 scan. And it shows the averages in 4 quadrants and also in 12 clock hours. Now, to get the next thing, as I said, was the macular ganglion cell inner plexiform layer thickness analysis. So here, what you require to do is retinal layer segmentation is required if you want to look at these layers. So the machine should have the capacity to do that. So Spectralis can get us, separate thickness of the GCL and IPL, whereas in Cirrus it comes together. In Spectralis, in a circular section is taken, whereas in Cirrus machine, an ellipse that is centered around the fovea gives us this thickness in this area. Again, 6 averages in 6 sectors are given and compared with the normative data. Now, let's see how to read these charts. Now, this is from the Cirrus machine, the RNFL chart. So what we see here is the RNFL thickness map. Here the warm colors like yellow and red, orange and yellow, they show thicker areas, and the cool colors like blue color show us the thinner area of the RNFL. On the right side is the RNFL deviation map, which shows us how it is different from the normative data. So how it compares with the normal people. If there is red here, which it shows that it's an abnormal thinning there. Then we have the actual parameters of the optic nerve head. That is, we have the rim area, disc area. You can actually get the objective data that how thick or thin the rim is. And we also have extracted horizontal and vertical tomograms. And this RNFL circular tomogram that we have here is actually the the retinal thickness here along this circle that we are seeing, that is around 3.4 millimeters away from the center of the disc. As I said before, the green is here, it is within the normal limits, the averages in the 4 quadrants and the 12 clock hours. This was about the RNFL. Now, similarly, we have a map showing the GCC thickness around the fovea. Again, warm colors show that this is, in this area, it is very thick, and the rest of the retina, it is thin. And adjacent to that is, again, how it is different from the normative data. So this is called the deviation map. Any red here in this area is going to show that this is a diseased GCC. And again, below is are the averages given in the 6 sectors. So before we start analyzing and using it in the clinical practice, we need to look for the artifacts. So a poor tear film can cause artifacts, motion artifacts can be there, segmentation errors can be there, mirror artifacts in myopic eyes are seen. So we need to rule them out before using it in the clinical practice. Now coming to the clinical use of OCT in neuro-ophthalmology, in optic neuritis, what happens is in any case of acute optic neuritis, whether it's a retrobulbar optic neuritis or it's an papillitis, there is some swelling at the optic nerve head, which is because of the exoplasmic flow stasis, and that shows up on the OCT as thickened retinal nerve fiber layer. So even if we have retrobulbar optic neuritis, you can pick it up. There might be, subtle RNFL thickening, which over a period of 4 weeks sets into RNFL thinning. So the pattern of thinning that occurs in the RNFL can give us a clue in optic neuritis as regards the diagnosis. If it's involving the horizontal quadrants, then it's more likely to be associated with multiple sclerosis. If it's in the vertical, then it's more associated with NMO spectrum disorders. But one thing is there, that RNFL thickness it does not correlate neither with the visual acuity nor with the visual fields. What correlates with these things better is the GCC thickness. So this takes around 2 weeks time to show up as thinning, the GCC thinning. And one thing that has been noticed is that severe thinning is seen in NMO spectrum disorders. Now, let's look at some cases. This is a case of MS optic neuritis on the left side.
Shika, your time is up. Maybe you can finish
in
about a minute.
Maybe I'll finish with the slide. Yeah, so in MS optic neuritis, in the acute case, 2 quadrants are in the left, in the right eye, you can see there is some amount of RNFL thickening, and in the other eye you can pick up the thinning, which is in the maybe because of the past attack. So it can be taken as a tool which shows us that there is a it can provide evidence of dissemination in time. This tool can provide, and similarly can provide the evidence of no evidence of disease activity. I think with that I'll stop. Thank you.
Thank you very much, Shika. Since the previous session overshot by 10 minutes, I will probably keep all discussions for all the topics at the end so that we can proceed on time. Thank you.
So I think we can move on to the next talk, and Dr. Naveen Jayakumar is going to talk on visual fields in neuro-ophthalmology.
Thank you very much for your attention. Before I start, a quick plug for neuro-ophthalmology. We have an organization called the Indian Neuro-Ophthalmology Society, and we have our annual meeting coming up this year in December 9th and 10th. I'm sure all of you will receive messages soon as we get the program and all, but do turn up. It's in Hyderabad this year. Shika spoke about the structural component of the optic nerve, which is OCT. I'm going to talk to you a little more on optic nerve function, which is the visual field, which is not just of the optic nerve, but the entire visual pathway. Now, if you look at the visual pathway, as far as the optic visual fields are concerned, you can divide them into 4 fairly distinctive regions. The first one happens to be the outer retina, which is your photoreceptors and the bipolar cells. And the general point here being that whatever field effect you get, it corresponds to a visual visibly lesion on the fundus itself. Moving a little back, you have the optic nerve, which is actually starting from the ganglion cells, and you have the classic defects like centrocecal scotomas, centroscotomas, altitudinal defects, the entire glaucoma fields, etc. Region 3 has a very characteristic defect, which is the optic chiasm. you have the bitemporal and the binasal hemianopias. And finally, the entire region behind the chiasm, the retrochiasmal pathway, results in homonymous hemianopias of different kinds and shapes if they happen to be incomplete. Okay, so let's start with the first one, which I will proceed here and give you a few tips and tricks and mistakes that can happen. I think all of you can recognize this kind of field effect. This is a classic one, very commonly visualized. It's a bitemporal hemianopia, and this is due to, in this case, a pituitary adenoma with suprasellar compression pressing on the optic nerve on the top. So this is classically region 3. Here is another example of another patient who complained of difficulty in seeing in his left eye, and you can see a very peculiar pattern on the field, which you may not entirely show what exactly this is. One thing that is missing that I am not showing you is this, because this could be a problem maybe in the fundus. Is there some lesion which corresponds to this defect? Could be, but let me show you the other eye now. This is the field of the other eye, and you can see both have exactly the same shape, and you can see that very typical stepladder kind of pattern, and this is due to an occipital cortex. In fact, this is a homonymous kind of a defect. So my first lesson here is always perform visual fields in both eyes for a correct interpretation. Okay. Here's another picture, and so based on the first lesson, you may ask me, where is the field of the other eye? And the other eye field is normal. This happens to be where the blind spot should be, so this is the right eye field. And you can see this defect here, which looks like a quadrantic defect, but you can see some spillover on the top. The moment you look inside the eye, what about the examination of the eye itself? Here you get a lesion, you have a choroidal scar producing the defect. So this is an example of region 1 where you have a visible fundus lesion and a defect that corresponds perfectly to that. Okay, so do your eye examination, make sure your fundus is looking fine. Okay, so coming to region 2, you can see here a classic central and centrocecal scotoma. This is very typical of optic neuritis. In this patient had a postneuritic optic atrophy. Here is another patient with an inferior defect. It's looking almost like an arcuate, but almost coming right up to the fixation. And this is due to ischemic optic neuropathy, which may produce altitudinal defects, but here is producing a very dense inferior arcuate defect. So this is region 2, which is the inner retina and the optic nerve. Now this is something that I showed you a couple of slides ago, something like this. And the first thing that you would think of, that this is a, anyone? Okay, so this is looks like a bitemporal hemianopia, but there's one little problem with it. Which eye is which? This is what it is. Okay, so this happens to be a binasal hemianopia, okay, and not a bitemporal one. So when you see interpret visual fields, please interpret it as if you were the patient. Place the right field in front of your right eye, the left field in front of your left eye, and then start interpreting it. Binasal hemianopias, classically one used to talk about giant internal carotid artery aneurysms, but many binasal kind of defects originate from within the eye. Neurological causes would include things like congenital hydrocephalus, etc. And sometimes you can even get a congenital binasal kind of a defect. Now, here's a patient of mine who had a known patient of pituitary adenoma. I've been seeing her over the years, as you can see, with normal vision, normal discs, and apparently normal looking fields over the years. And then I missed seeing her for the past 3-4 years due to COVID until she came this time. This time the discs was a little pale. And this was the field defect that we saw. You can see a temporal kind of a defect respecting the vertical meridian in the left eye. The right field looks normal, and here is this huge tumor. It's now expanded upwards. The optic chiasm has slid to one side, and therefore the tumor is actually pressing, or the junction of the right optic nerve and the chiasm, and that's where the inferonasal peripheral fibers of the opposite eye cross. And that's why you get this upper temporal peripheral defect only in the left eye. If you look back now at the field of 2018, you can actually see that defect on the side in this 30-2. This is a classic traqueous junctional scotoma. The lesson to be learned here is in a unilateral optic neuropathy, the neurologically more important field is that of the contralateral eye. Okay, the eye which is apparently normal. And remember that central 30 degrees or 24 degrees may work for all neurological lesions in the entire visual pathway, but you might sometimes miss things like a junctional scotoma. So depending on the risk and your clinical intuition, be prepared to do a larger field. Now we move on to homonymous defects, and here you can see this defect, which is not a complete defect. It's not even a quadrant, it is a sector, and these are very typical of lateral geniculate body lesions. Here is another picture. So this is the retrochiasmal area. We are in the region of the homonymous hemianopias now. So when you have incomplete, the entire hemifield is not involved, then you can make some assumptions as to whether it is LGB or tract or radiations or cortex. Okay. Here is another patient of an LGB lesion, but here you have the central area sector is spared, the upper and lower sectors in the hemifield are involved. This is therefore called a quadruple sector anopia, also an LGB lesion. From a sector, we now move to quadrants. This is a superior quadrantic defect on the left hemifield. And as you know, these are in the regions of the radiations. This is the temporal, inferior radiations in the temporal lobe. You can see that infarct there, which has produced that defect. On the other hand, although if you ignore all the noise on this fields, you can see that there is an inferior quadrantic defect on the left side, and this is due to a parietal lobe hematoma in this patient. My last message is always perform confrontation fields. It's something we often miss, especially in a patient with poor visual acuity where you cannot do a formal field testing, because a defect on a temporal side on confrontation is as significant as performed by, say, a Humphrey field. Okay, a color confrontation is an entity, and sometimes certain diseases like hemi-neglect, which involves the right parietal lobe lesions, can only be picked up by confrontation visual fields. My last slide is a quick summary. Therefore, when you have a field defect, get both fields, place them correctly, and decide whether it's unilateral or bilateral. If it's unilateral, it's the retina and the optic nerve. If it's bilateral, is it respecting the vertical meridian? If it's not, look at the retina and nerve, and if it is, then you're dealing with a hemianopia, which comes in two flavors, the homonymous and the heteronymous, which is a bitemporal or a binasal defect. You know where those come from. If it's homonymous, is it a complete homonymous defect? In which case, it's somewhere in the retrochiasmal on the opposite side. But if it's incomplete, you can make assumptions as to whether it's coming from the optic tract, LGB, radiations, or cortex. Thank you.
Now, our next speaker is Dr. Swati, and she would be talking about traumatic optic neuropathy.
Sir,
So you're basically saying that there is ganglion cell issues, but not a corresponding field?
no, the other way around. He says that there is a field defect, but there is nothing in OCT.
Well, one typical... I'm not entirely sure if it's in the anterior visual pathway, whether you would get GCL changes. It depends upon how posteriorly the lesion is located.
Please talk in mic, sir.
Can you use the mic, sir? I think everyone else can hear it.
In the pituitary apoplexy, the lesions produce immediate field changes, but the GCL takes more time.
So it
That
takes
is one
2
condition.
weeks.
I don't know whether there are other conditions also which will stimulate.
Yes, any lesion which is posteriorly located along the axon will take time for it to produce changes on the GCL. So an apoplexy is a catastrophic event, so you wouldn't get any
Immediately the
changes.
field effects comes, but the GCL takes time.
Yes, I agree. Thank you. We'll move on to the next talk. Swati, go ahead.
Yeah, thank you, Dr. Ashmin, for this opportunity. And I would be talking about traumatic optic neuropathy. So, as a neuro-ophthalmologist, we all know that's a very dry topic. We can't do much about it. But yes, we have to live with it because as the incidences of road traffic accidents are increasing day by day, so is the incidence of traumatic optic neuropathies. So it's a vision-threatening condition that can be caused either by ocular trauma or head trauma, with incidence more in cases of closed head trauma. The injury can be a direct injury or an indirect injury. Now, the direct injury is one where the optic nerve is directly, disrupted, like in direct transaction, which is more common with injuries to head, face, and orbit. The force is if transmitted through the optic canal, and generally it is the fracture of the optic canal, the bony fragment impinging on the optic nerve, leading to the traumatic optic neuropathy. The other mechanism could be a foreign body which is acting as a projectile and gets lodged in the optic nerve. The third mechanism could be direct penetration of the foreign body, and it is just penetrating trauma rather than the closed trauma. Now, indirect injuries, interestingly, is not so visible. You cannot, see it. So it's like because of the force which is transmitted through the bony orbit to the optical canal. And as we all know that the optic nerve is very tightly adhered to the periosteum at that region. And that's the reason why it's the most common site of indirect trauma. These forces get transmitted, and then there is a shearing of axons leading to a traumatic optic neuropathy. So as I said, because the optic nerve is tightly adhered at that region, it is the most common site of indirect traumatic optic neuropathy. Other than that, you may have hemorrhage within the optic nerve sheath, or there may be associated orbital hemorrhage, causing orbital compartment syndrome and compression of optic nerve. So coming to clinical features, as I said, it is more commonly seen with blunt trauma on the face, specifically at the brow. So any trauma which is a hard-hitting trauma at the brow, one should suspect of traumatic optic neuropathy. Visual acuity is almost always involved. Sometimes it may be as severe as nopial, or sometimes it may just be a mild in form of 6/12 vision. RAPD will be present, as in any case of optic neuropathy. If it is associated with proptosis or disc edema, then most probably there is some kind of compression, particularly orbital hemorrhage. Anti-injuries will cause avulsion of optic nerve, which is seen as ring of hemorrhage. It compromises the retinal vasculature and the entire total retinal ischemia. While the posterior injuries, you may have absolutely normal looking fundus. However, about after 6 weeks or so, or maybe after some time, there may be dyspallor, maybe the only sign or evidence of the trauma there. Investigations, now we have to understand that CT scan and MRI both are required. They are complementary to each other. CT scan will help us in knowing if there is any bony fragment that is impinging on the optic nerve, while MRI of the optic nerve will give us an idea if there is any intrasheath hemorrhage or not. So the both of them may sometimes act complementary to each other, but what we have to remember is that whenever we are ordering these scans, we should have a dedicated optic nerve scans rather than just an entire screening brain or screening orbital scans. As far as electrophysiology is concerned, they may not predict, they may not be able to help in diagnosis of these cases, but they can definitely predict prognosis to certain extent. So flash EVP less than 50% of normal amplitude are suggestive of good prognosis. Bad prognosis. However, an absent ERG is suggestive of bad prognosis. Management remains controversial. We still don't have any treatment for this condition. We don't know what we have to do. Most of the time, we rely on the guidelines that are available, but there are no fixed guidelines. Each case has to be individualized. So we have to know whether we want to do observation to surgical decompression. Everything has been described. And it has been seen that around 25% of cases to 50% of cases may have some improvement. It may not be an entirely normal improvement. They may not gain their entire vision, but some amount of improvement may be there if it's an indirect traumatic optic neuropathy. And the baseline visual acuity is the most important predictor of the final visual outcome. Generally, patients who have orbit traumas, particularly optic canal trauma, have a very bad prognosis. So these are two important studies done in cases of traumatic optic neuropathy. One of them, spinal cord injury studies, have shown that probably high-dose steroid, bolus steroid, can have some useful effect on the traumatic optic neuropathy. But entirely converse to that, it is the crash trial which said that it not only has no benefit, but can be detrimental to certain extent in cases of head injury. So we do not have any clear-cut evidence of saying whether it's useful or not useful. Maybe panel and the dais can throw light upon, give their own opinions about the same. Then you have something as International Traumatic Decompression Study, which have studied the role of observation versus high-dose steroids versus optic canal decompression within the 7 days injury. And they have concluded it's neither the timing nor the type of treatment. Nothing matters when it comes to traumatic optic neuropathy. But yes, there are certain indications where your surgical intervention, where your intervention on time will make a lot of difference in patient's life. So if you have a clear-cut orbital hemorrhage, we may have to decompress it by doing cantholysis. That will relieve the edema, that will relieve the compression, and patient may regain his vision. If there is retrobulbar hemorrhage, again, it's important to decompress it. Sometimes decompressing the optic canal, removing of the bony impacting bony fragment can also help in the recovery. Similarly, ONSF may be indicated if there is intrasheath hemorrhage. Thank you.
Thank you, Swati. It was brief and sweet.
Thank you. There was nothing much to speak, so you know it.
I think all the key points were covered.
Right.
Thank you. Shall we move on to the next one?
Yeah, may I now invite Dr. Padmavati for her talk on sixth nerve palsy.
Thank you. At the outset, I'd like to thank Dr. Rashmin for giving me the topic to speak in this session. The topic assigned to me was sixth nerve palsy. As everyone knows, sixth nerve palsy, known as the abducen nerve, which innervates the lateral rectus. The course of the nerve is very long, and you have any lesion or affection of the nerve, you can localize the lesion based on the associated neurological conditions. But as such, when you have a sixth nerve palsy, there is a limitation of abduction on the same side. You have an concomitant esotropia towards the paretic side. There is a face turn to the affected side with floating saccades, and you have an esotropia maximum on the side of palsy. The epidemiology, as everyone knows, of all the oculomotor nerves, sixth nerve palsy is the most commonest seen. This was the largest study which was done and published in the 1992, where they found the incidence of cranial nerve sixth nerve palsy was around 43.8% when compared with the other cranial nerves. So the incidence of abducen nerve palsy was around 11.3 in 1 lakh. This was a recent article regarding the epidemiology where multiple studies have shown. This was published in the Journal of Clinical Neurology, and this study was a prospective study. If you see in all these cases, the sixth nerve palsy has a greater incidence and microvascular ischemia being the commonest cause. This was a prospective study from our institute where we found that the sixth nerve palsy was the commonest. The etiologies of the sixth nerve palsy by anatomical location, if you have at the nuclear or the fascicular, it could be either due to infarction, tumor, or demyelination. In the subarachnoid space, it could be due to either meningitis or raised intracranial pressure. In the petrous apex region, it could be the gradinigos or a clivus tumor. In the cavernous sinum, it could be a cavernous sinus, it could be an aneurysm, carotid cavernous fistula. It could be idiopathic or inflammatory or infection. The same holds with the orbital. In addition, you have the neoplastic lesion. So I have 6 patients who are in the different age groups. Let us look into it with all the details, clinical features. This was my first patient. She's a young child. She has an abduction limitation of the left eye. It was of acute onset, 2 months duration. So the next plan, what would you do? The imaging was done. It was suggestive of a left-sided cavernous hemangioma. Any child with acute onset of ET, you have to image. This was a 20-year-old with right eye 6-nerve palsy. The MRI brain was within normal limits. The clue was in the fundus, which showed disc edema. The diagnosis was IAH. But I think here it doesn't end here. You have to do a venogram where there was suggestion of sinus thrombosis with collaterals, I can see with the markers. So this was a case of cerebral venous thrombosis. The next patient is a 67-year-old. He had a 6-nerve palsy of the left side. He was observed for 2 months. It was not resolving. So what do you think? Will you take this as a microvascular ischemic associated neuropathy, or will you image? But this patient, I had done an imaging after 1 month because it was non-resolving. There is an aneurysm involving the basilar part of the vertebral artery. The next patient is a 65-year-old. She had an acute onset of ET. She was a known hypertensive. Will you take this case as an ischemic 6-nerve palsy? I think there was associated of 5th, 7th, and 8th nerve involvement, which was suggestive because there were no, it was not an isolated. When it was a multiple cranial nerve palsy, you have to image the patient. So the imaging was in surprise where it was suggestive of multiple metastasis. You can see the metastatic lesions in the cranium as well as in the muscle belly. The next patient was a 70-year-old. He was a known hypertensive and diabetic, 6-nerve palsy. His glycemic control was poor, which was suggestive of a ischemic 6-nerve palsy. My last patient, this is one interesting case which was reviewed. She was a 47-year-old. She had recurrent 6-nerve palsy. Okay. If I show you the timeline, she presented to me in 2021 with 6-nerve palsy. I had imaged because she was young, within normal limits. January she had resolved. In March 2022, she had a recurrent 6-nerve palsy. I think again I started her on steroids. It was asymptomatic. She was lost to follow up with me in April. She presented with, in May with total ophthalmoplegia to a different institute where they had imaged and treated her with steroids. And she has been on oral steroids and immunosuppressants since then. So where have we gone wrong? Actually, you may need repeat imaging when the patient comes with recurrent 6-nerve palsy. You have to question yourself what could be the cause. And this was the picture which is of latest, where she has an hyperintensity along the tentorium cerebellae extending to the anterior cavernous. You can see there is a hyperintensity along the meninges, which is more suggestive of hypertrophic pachymeningitis, which was not evident. She was investigated, it was suggestive of a granulomatous etiology, suspecting sarcoidosis, but the ACE levels were absolutely normal. The last patient, this patient was referred as a case of 6-nerve palsy, but if you see the extraocular movements, it was a clinical case of Duane's retraction syndrome. So whenever you have a 6-nerve palsy, go for identify whether it is isolated, multiple, or recurrent. You have to go with all the cranial nerve examination. Assess the pupil is more important. The imaging is when it is less than 50 years, I think. You have to see whether it is associated neurological factors, or you have any progressive cause of double vision, or it is long standing, or any malignancy is associated. This holds good when it is more than 50 years. Apart from that, the imaging characters, you have to take into account what sort of imaging you need. Just an MRI brain is not going to be there. You have to go with gadolinium enhanced with contrast. Okay. So this was a multicentric study which assessed whether neuroimaging is needed in acute isolated palsy, where they found that even in you have associated vascular risk factors, they had some more 16.5% of the cases had other etiology. This is one study from the SN where they had found what was the diagnostic yield. So they found the cause in 48.64% of the cases. So isolated 6-nerve, non-resolving, no cause found, again re-evaluate for myasthenia gravis. If it is a recurrent, you have to keep your options wide, whether it is due to uncontrolled diabetes, multiple sclerosis, or is it migraine or myasthenia gravis, or any connective tissue disorders and vasculitic workup, or is it a recurrence of tumors. Not all esotropia are due to 6-nerve palsy. You have to think of myasthenia gravis, any thyroid eye disease, DRS, or a fracture of the medial wall of the orbit, or convergence spasm. The management includes you give a ground glass, occlude one eye with till the 6-nerve resolves, or you could prescribe a Fresnel prism, or you go for temporary injection Botox, or a long-term 6-nerve palsy, go for a surgical correction. This was one of the cases where we had given injection Botox. The left eye, this was a left ischemic 6-nerve palsy. So botulinum toxin in the early treatment, this you have to advocate in the early months only, not on long-standing cases, you will not have any effect of the Botox. So this was a study which was done from Coimbatore, where they found that 90% of the patients had full resolution of symptoms in the last visit. So whenever you have a 6-nerve palsy, find out whether it is isolated or non-isolated, whether it is painful or non-painful, rule out any trauma or malignancy, age of less than 50 years, do a neuroimaging, age more than 50 years, do all the vasculitic systemic factors, vascular factors, observe. No, still you don't find improvement, go for neuroimaging. Thank you.
Thank you so much, Dr. Padmavati. Very nicely, I think, briefed, because 6-nerve palsy is the most common thing we all see. But just that, as you say, the ocular disease like Duane syndrome and myopic strabismus fixus, because personally I have seen high myopia cases with displaced pulleys getting 8 to 10 MRIs before they come. In terms of systemic, always think about medical, migraine, and myasthenia. This is important because this is somewhere, because 90% of the patients will have MRI before they come to us. So what to look is very important. Thank you so much for summarizing it. I would like to request Dr. Jyoti Matalia to talk about the biggest masquerader in neuro-ophthalmology, ocular myasthenia.
Thanks, Ramesh. And I thank Dr. Rashmin to have given this opportunity to be a part of the National Symposium. So I'm going to be talking and giving you a brief idea of what is myasthenia gravis, the pathophysiology, the diagnostics, and management. So let's go through it. I will be primarily discussing about ocular myasthenia gravis. As you can see the graphic there, it is a chronic autoimmune disorder of the neuromuscular junction. Primarily affects only the muscles that move the eyelids and the eye, the extraocular muscles as you can see here, and the LPS. So let's understand why that happens. Now we know that as acetylcholine is released at the nerve terminals, it binds to the acetylcholine receptors as you can see, and then there's an initiation of the action potential and the muscle contraction. But in myasthenia gravis, there are acetylcholine receptor antibodies that destroy these receptors, resulting in reduced amount of receptor and therefore less acetylcholine to bind to the terminals and easy fatigability. The other important proteins that we are aware of, the muscle-specific kinase and the LRP4, are required for clustering of the acetylcholine, and that also is reduced in cases with myasthenia. So what are the important things that we should understand? Primarily, ocular myasthenia gravis is a clinical diagnosis, but you may need other tests in subclinical cases. So what are the clinical things that we are looking at? It is primarily the ptosis that can come either bilateral or unilateral, and if there is unilaterality, there may be a lid retraction of the other eye, and a classical eyelid curtaining sign, in which if you look at this patient, he has a right ptosis, you can see. As you lift the right eye ptosis, you will see that the other eye droops. So that is a classical feature that you get due to Herring's law. Then the other is diplopia, resulting in due to ophthalmoparesis or unexplained ocular motility. But remember that in all these cases, the pupils are perfectly normal. Now let's look at the various tests that you can do. The fatigue test, that when you make the patient on sustained upgaze looking, you'll see that the ptosis worsens. And then the classical Coggan's lid switch sign, when you make him look from down gaze to up, you'll see the lids twitching. So this is classical feature. So as mentioned, you can actually pick up myasthenia just looking at the patient carefully. Then you have an ocular motility which is not explained. As you can see, the right eye perfectly okay, but there's an adduction limitation in the left eye and an elevation limitation in the left eye too, which is not clearly explained. You should know that it can affect any age group. It's clinically isolated to the extraocular muscles, the LPS on the orbicularis oculi, and can mimic any cranial nerve palsy, gaze palsies, internuclear ophthalmoplegia, and blepharospasms as well. So keep in mind, remember, it's a great mimicker. Coming back to the orbicularis oculi, this is a peak sign of ocular myasthenia gravis. On sustained eyelid closure, as you can see here, patient is unable to maintain the closure and slightly opens up like a peekaboo sign. That is a classical orbicularis fatigue you can see. So remember, it's a clinical diagnosis provided you have a very good history and examination findings are classic. But for subclinical cases, you have to do the other tests. So what are the various tests? Classically, the ice test, a simple and effective test. You apply ice for 2 minutes over the lid, ensure that the ice is actually touching the lid eyelid so that you can see that it relieves. As you see here, after 2 minutes, you will see an immediate response. It's very effective, but absence of ice test does not rule out ocular myasthenia. Then sleep test, yes. The best thing about this is ask the patient when he gets up in the morning or after an afternoon nap, is the ptosis completely relieved or not? And sometimes in children, you can take photographs and compare to see that this is actually working or not. Then we have the edrophonium test. However, we don't have Encelon available in India. But the neostigmine is a long-acting, but after 30 minutes, you can see an improvement happening. The sensitivity of the test is 95% in generalized and about 86% for ocular cases. Then coming to serology, when we are unable to get those, we can look at serology, the anti-acetylcholinesterase antibodies, more specific, but not much for the ocular cases. Then you have the anti-MuSK antibodies, which only 5% of them are positive in the cases of ocular, and anti-LRP4 antibodies you can see. But remember, there could be 10% of cases of ocular where all these three antibodies are negative. When you are unable to pick up on serology, you look at the electrophysiology. You can see the single fiber electromyography is very specific for ocular cases, but it is operator dependent. It's very difficult to perform and needs a patient cooperation significantly. And then finally is a repetitive nerve stimulation study, but does not have very high results in cases of pure OMG. But if you are looking at the muscles of the orbicularis oculi, it becomes easier and gets better results in those cases. And finally, the other tests, which include the CT scan to detect any thymic hyperplasia or thymoma, and thyroid function, because concurrent myasthenia can exist with thyroid eye disease. So now we can go to the management. There are two ways of treating: increasing the acetylcholine availability at the neuromuscular junction or preventing the acetylcholine receptor binding with the antibodies. For that, we can start with the pharmacological agents. As you can see, these three important drugs, starting with pyridostigmine. It's a proto-drug and acetylcholine receptor inhibitor causing prolongation of the action of acetylcholine at the neuromuscular junction, but no effect on natural history. Unfortunately, with ocular cases, it is not as favorable. Corticosteroids are the second line of treatment, and about 80% of ocular myasthenia exhibits significant clinical improvement and can be given along with the pyridostigmine. So there was a study done, which was a randomized controlled trial, double-blind placebo-controlled, and they wanted to check the safety, tolerability, and the effectiveness of prednisolone in these cases, along with placebo. They started with a low dose of 5 milligram every 5 days till the symptoms resolved, and they found that 5 of the 6 cases on prednisolone had better results, unlike the placebo. And they found that the best dose that gave the resolution of symptoms was 15 milligram per day. Then the immunotherapeutic agents, which are important for long-term cases, and when corticosteroid risks are much more than the benefits. There are studies that show that the conversion to GMG, that is a generalized case, is significantly less if you give the immunosuppressive agents. Now that is important in severe cases to allow long-term immunomodulation, and this includes azathioprine, which is good for ocular as well as generalized cases, then mycophenolate mofetil, which is good in ocular cases, but IVIG and plasmapheresis is reserved for severe cases and in generalized along with rituximab. Then coming to the surgical options that we can look for are thymectomy, which is beneficial in patients during the course of the disease with significant follicular hyperplasia of the thymus glands. But in non-thymomatous ocular cases, complete remission has been achieved in 50% cases and symptoms improved in 20%. It may be considered in cases where acetylcholine receptor antibodies seropositive cases who are not responsive to medical therapy. So finally, an important algorithm for ocular myasthenia gravis. A clinical examination is very important, followed by eyes and sleep test, look for the fatigue test, look for any signs of generalized, and rule out alternative neurological pathology. Once you're able to clinically suspect it, you can do the antibody testing as mentioned. If it's seronegative, you can do electrodiagnostics as mentioned here, and if consistent or if seropositivity is noted, you are confirming the diagnosis. However, if that's negative, you may have to redo an MRI, find out if something else you're missing. You can start an empirical treatment and see if there's an improvement noted, and repeat the antibody testing again 6 to 12 months, and all of this can help confirm the diagnosis. Hence, to summarize, ocular myasthenia gravis is a clinical diagnosis when you have a good history and examination findings. Remember, it's a great mimicker, so any cases, keep that in the back of your mind. If suspected, if you're looking at any case of ptosis, diplopia, which are not fitting into any diagnosis, give importance to the history of variability and fatigability, look at photographs, ask good history from parents, especially in children. And remember, don't get biased by diagnosis done elsewhere. Coordinate with the neurologist to rule out any generalized cases of myasthenia. Thank you very much for your patience.
Thank you, Dr. Jyoti. And we come to the last talk of the session, and after that, we'll have a panel discussion. May I invite Dr. Vikas for his talk on interesting cases of IIH. Dr. Vikas joins us from SGPGI, Lucknow.
So good morning, everybody. I would just like to thank Dr. Rashmin Gandhi and Dr. Naveen J. Kumar for giving me the opportunity to be over here to present. And I would be presenting 3 cases of intracranial hypertension, which are having a secondary cause. So just to brief about intracranial hypertension, it is a syndrome of increased intracranial pressure, primarily when there is no cause, and secondary intracranial hypertension when there are causes to that. There are 2 studies from Neurology 2004 and 2008, which depicts that brain venography, because that now the imaging is emerging with the newer diagnostic tools. So brain venography imaging have shown that most patients with IIH may have structural abnormalities of the cerebral venous sinus system. And of that, more prominent was the stenosis of the transverse venous sinus. Since the disease is often refractory, multimodal treatments are often employed, including weight loss programs, carbonic anhydrase inhibitors, and your Lasix and topiramate, therapeutic lumbar puncture, LP shunt, for overall symptomatology of that your intracranial hypertension. Apart from that, despite these strategies, 38 to 45% of IIH patients experience eventual symptom worsening or recurrence within 6 to 10 years. So a little bit about the CSF flow. It is clear fluid in which the brain is suspended. It is formed in the body of the lateral ventricle, third ventricle, and fourth ventricle. From there, through interventricular foramina, it goes to third ventricle. From there, to cerebral aqueduct, to fourth ventricle, and from there, in the CP angle system, that means the cisterna magna and the CP angle system are the subarachnoid spaces in the base of the skull, and through those, that lateral and median aperture, it goes around the spinal cord, circulate through the medial canal of the spinal cord, and ultimately it drains through those, the red circles, the arachnoid villi, that are the projections into the venous sinuses from the subarachnoid space. And from there, the venous sinus, as you can see in the last picture I just projected, superior sagittal sinus, transverse sinus, and sigmoid sinus. From there, it goes to IJV, that means internal jugular vein, and from there to heart, and then it recirculates. So my concern would be the reduced drainage of CSF across arachnoid granulation, that means from increased venous sinus pressure, that means the venous sinus stenosis. So I present my first case. It was a 50-year-old female presented with complaint of headache, tinnitus, decreased vision in both eye in last 8 to 9 months. The vision was 612 in both eye. This was the fundus picture. This was generalized constriction of field. The RNFL was raised, as you see, and this was a T2 axial, T2 weighted axial image of the brain. You can see this is showing partial empty cella, the arrow indicates, and increased CSF space around the optic nerve sheath. So MRV of that case was done as a routine protocol at my center, and you find this is the arrow green, the stenosis, typical stenosis at the junction of the transverse sinus with the sigmoid sinus. And the left, the yellow one, is the left transverse sinus, which was hypoplastic. So a diagnosis of intracranial hypertension was made. Patient was started with neurology consultation because the stenosis was there. Thrombosis was, cerebral venous sinus thrombosis was thought of. And with the neurology people, because they are more resistant to other strategies, so we started the patient on acetazolamide, furosemide, and oral anticoagulant. Then the patient came to us again because the headache was persisting and it was very disturbing, vision deteriorated. So there was an evidence of that stenosis. So, and on the finding of the MRV. So what was planned was a DSA, digital subsection angiography. And you can see over here, it is a catheter venogram that starts from, you just puncture the femoral vein and go to the brain, and you inject the dye with digital subsection angiography. This is the venogram. As you can see on the right side, both transverse sinus and the IJV is seen. So there was a stenosis of the right transverse sinus. On the left transverse sinus was hypoplastic. So what was done? Again, just like in your coronary angiography, the stent was placed through that catheter, a balloon was placed to inflate that sinus, and the stent was placed. As you can see over here, the mesh is there, that is the stent in the transverse sinus. So the symptomatology of the patient also relieved. This is what the post-stenting venogram, which is showing a patent transverse sinus. So papilledema resolved, and the vision was further improved to 612. That your RNFL shows further decreasing. So case 2 was an interesting case. Last December, this patient came to us in our OPD. She was having tinnitus for last 6 years, which was becoming bothersome in last 4 to 6 months. Earlier in 2016 in Bareilly, she was diagnosed as a case of IIH for her headache, which was there for past 3 months, of transient obscuration of vision, and tinnitus, which was there but not that bothersome. So she was diagnosed as a case of primary IH at Bareilly, and she was started on acetazolamide and furosemide. Later she was seen by a neurosurgeon who did lumboperitoneal shunt because her symptomatology was not improving, but that didn't work. So that patient on her own, because now with an year or two, she just knew that everyone, where she goes, they gave Diamox, furosemide. So she started taking her own treatment with Diamox. But for last 6 months, when she came to our OPD, that headache again appeared, and she was having that your blurring of vision. And tinnitus also become very bothersome. It was more a prominent point which she came to our OPD, the tinnitus, and now that because the papilledema has again been diagnosed. So we just discussed with our neuroradiologist. So, and because this was that fundus picture, the C halo on the nasal side, a little bit enlargement of the blind spot, that this is now. This is the MR venogram. With contrast, as you can see, the stenosis of the, again, right transverse sinus and left transverse sinus was hypoplastic. So considering her this 6 years of history and that tinnitus which was very bothersome, again DSA was done, and which is showing a stenosis. And importantly, what we do with the catheter venogram, we put the catheter into the distal and the proximal segment where the stenosis is, and you can very well see the 42 millimeter and 10 millimeter. That means there was a difference of 32 millimeter, and it was very much high. So that balloon angioplasty and then the stent was placed, and post stenting that the pressure gradient in the proximal and the distal segment, it reduced, and her headache reduced, and importantly within a day she was just very happy that the tinnitus was not there. So last case, 35-year-old male patient presented with complaints of hollow cranial headache associated with pain in neck, transient obscuration of vision and decreased vision for 3 months. On examination, the vision was 6/9 and MRI was showing flattening of the sclera and optic nerve sheath spaces, they were enlarged. Vision, that field was generalized depression, and features are again suggestive of right transverse sinus stenosis with left transverse sinus hypoplastic. CSF opening pressure was done in neurology, and it was more than 400 millimeter. Again, they started with acetazolamide, furosemide, oral greaseline for 1 month, but didn't improve. So his vision again deteriorated, and again the DSA was performed in the neuroradiology department, and there was a pressure gradient of 26 millimeter. Considering this, balloon angioplasty and stent was placed, and he remained asymptomatic after stenting for a period of 3 months. But again, there was a recurrence of symptoms, and the patient came again to us. A repeat DSA was done. The stent was there. Transverse sinus was again patent. But importantly, as you can see, there was dural AVM, AV malformation in relation to right transverse sinus with retrograde and antegrade flow, but no sinus stenosis. What they were doing, they were increasing the venous flow. That means the venous pressure was increased because of this dural AVM, and that was the reason for the recurrence of the symptom. So that they were embolized with glue and onyx, and the symptomatology reduced, but the optic atrophy has set in the right eye, but the left eye papilledema has resolved. So these are the meningeal arteries and dural vein, that combinations or that malformation which usually develop at the junction of the transverse and the sigmoid sinus. So I would not go into detail of this. There's a Borden classification, Conard classification for these. We also published from our center a case series for 4 of these cases of dural AVM where there was recurrence of symptom after stenting, and again after putting that glue, the symptomatology reduced. So now there are studies coming on with in last 2 years, there are studies, this was studies and from the Frontiers in Ophthalmology. This was published by some group in Australia, Canberra, and they concluded that medically refractive disease, that is IH, is common and nearly always associated with a significant transverse sinus stenosis pressure gradient. In 90% of patients, which they observed, and endovascular stenting of the stenosis deserves wide uptake as a highly effective, safe, and usually definitive treatment. It safeguards vision by eliminating papilledema and allows most patients to cease acetazolamide. And importantly, what is this medical refractory? This is progressive visual field loss on maximal, that your drug therapy, persisting papilledema, recurrent papilledema on weaning of drug therapy. That means whenever you are stopping acetazolamide, and they just other studies which concluded that there are medically refractive disease associated with significant transverse sinus stenosis. Such patients have historically progressed to CSF diversion with a shunt or optic nerve fenestration. More importantly, headache was or tinnitus, there were other symptoms which are more prominent in these patients. So that MRV was done, stenosis was thought of, and then the stenting was done considering the tinnitus or headache, and also the papilledema or the transient obscuration of vision or deterioration of vision. So there is another study, the last one. This is the last slide. So another study which shows that stenting treatment group had a greater proportion of patients with complete resolution of symptom at 1 month than the medical treatment. I think MRV with contrast is very important in these patients. If lumboperitoneal shunt or optic nerve fenestration may be considered prior to stenting of venous sinus. And finally, if the pressure gradient across on DSA is more than 10 millimeter, then these patients should go stenting. I think this is the last slides. Thank you.
Thank you very much, Dr. Vikas. And I would like to thank all the speakers. Despite getting the hall quite late, we have finished nicely on time, and we are around 15 minutes for the discussion. So Let me first invite our panelists to have comment or question on any of the talks so far, and also from the audience. Sujata, Murli, Dr. Anita.
One question I would like to ask, how easy it is to measure the gradient between the two sides of your stenosis. Is it a standard procedure when you do the DSA? How easy is it?
You can come there.
So whenever you are finding that stenosis on the MRV, and if the symptomatology is there, just like in my second case, the tinnitus was persisting for last 6 months, 6 years, and it was becoming bothersome. So we just discuss with the neuroradiologist. There in the DSA room, we do the catheter venogram, or you can say the DSA, and it is very much easier because this catheter goes through that stenosis area, and it goes into the proximal and the distal segment, and they can measure. That is very much easy.
Like to ask is that how often we usually finish with the MRV. So in case we see any stenosis on the MRV, do you advise DSA, or should we limit it to only patients who are not progressing?
Patients initially, even if the stenosis is there, they are just put on the medical treatment. If they are improving on medical treatment, there is no need to go for DSA. But if the persistence of that means the vision is deteriorating, the headache is still persisting with your maximum medical therapy, that means you are going up to 1 gram or maybe 2 gram, or book says 4 gram up to acetazolamide, you have added topiramate, or you have given the furosemide also. Even then the symptomatology is not improving, then definitely DSA is a choice.
I just have 2 points to make there, ma'am. One is earlier we just used to say MR venogram, but just remember that nowadays it's considered MR venogram with contrast for IIH. That's number one. And number two, as far as DSA is concerned, I can say now definitely that any patient who is undergoing a filtration shunt procedure for IIH, the neurosurgeons are doing a DSA before that procedure, because you never know who has an AVM, and doing a shunt in those cases doesn't really help out very much.
I would have add upon to this MRV and with contrast, because there is a controversy always that which came first, hen or egg, whether that stenosis is causing your the symptomatology of that your IIH or the IH, or whether the IH which is causing the compression of the transverse sinus.
True.
So there comes the role of the contrast, because with contrast you can delineate whether it is an intrinsic or extrinsic.
Yes.
Because if it is a collapse of transverse sinus, it would be a smooth one. But if it is a stenosis because of any reason, intrinsic or extrinsic, then there would be a chink in the transverse sinus, and there comes the role of contrast.
Thank you, Vikas.
And
Yeah, any other comments?
yeah, sometimes this narrowing of the sinus could be because of the hypertrophic arachnoid villi. That can also be a cause of obstruction to the sinuses. Sometimes there is a congenital septum has been reported, causing the focal narrowing of that sinus. So DSA would be helpful in these cases. And secondly, the type of narrowing. Sometimes the raised pressure in IH may cause collapse. So they have demonstrated that after the LP, they repeated the MRV, and they found that collapse disappeared. So that was the raised ICP. And when there is a thrombus which resolves and results into the narrowing will have a crenated margins, they have said. So that would also give you a clue about that.
Rashmi, shall we
Yeah,
try
Shikha.
some other topic?
Shikha, you wanted to ask something?
Yeah.
I just want to know that these patients, they can be, it seemed a very good option to manage these patients with stenting. And you've definitely shown excellent results. But for how long these patients are kept on blood thinners? I suppose they're on blood thinners, and keeping young patients, how safe it is? What's your experience? You have quite a bit of experience managing these patients with the stent. Actually, of all the three options, medical management, certain cases are there, the IH doesn't settle, it goes on and on for years, comes back, you stop the treatment. Then you have to decide between lumbar puncture and stenting. So of the two, how do you compare stenting with the LP? The only concern, stenting, I believe, is showing good results, immediate results. It's not that difficult. You just go. Though you said that measuring the pressure gradient and all, I'd say it's a little more invasive than a lumbar puncture. What do you say? What are your comments? There are only two things to it, for us to go fully on stenting. This is the first time we are having this kind of discussion on stenting for IIH, at least in Indian Neuro-Ophthalmology. So I think it's very important to get a couple of things clarified, that how invasive is measuring the pressure gradient. Can we really bring it into, do it as simply as doing lumbar puncture? And second thing, how safe is it to keep the patients for, a long duration on blood thinners, and what's the dose?
Regarding your first question, blood thinners, those patients of anticardiolipin syndrome, CVST, they are put on that your antiplatelet drug lifelong. This is what the neurologist says, and this is the practice is. So regarding this question that the blood thinners, usually they are started 7 to 8 days before that your catheter venogram. On the day heparin bolus is given and the venogram is done, and they are put on for 6 to 9 months minimum after stenting, because there is always a chance of stent being blocked by the thrombus. So they are always put for 6 to 9 months on
Is it single
antiplatelet.
drug or two drugs? It's
Yeah, single drug,
aspirin,
single drug.
simple.
We are putting the patients
Ecosprin.
on Ecosprin 75 milligram HS. That is what we are practicing. Regarding your second thing, that the lumbar puncture and the stenting, definitely the studies are there. You do lumbar puncture, as the madam was saying, Dr. Kumudni, there can be a regression of that collapse of the transverse sinus. It can again regain its size, but the studies definitely say after lumbar puncture, maybe 2 or 3 months
No,
again.
I didn't say lumbar puncture. I said shunt.
No, shunt. Now I'm coming on to shunt.
I'm not, talking about repeated draining of lumbar puncture. It's like between the shunts and
lumbar puncture can
stenting.
also be an immediate option, just to relieve the pressure, to release that collapse, because the study says that. Regarding LP shunt, I would just come to the mortality, the studies. I will not quote it because of the paucity of the time. There is always the failure of the lumbar peritoneal shunt or any that your VP shunt, whatever it is. Definitely there is a failure in 5 to 6 years. Reinfection, infection, and revisiting of shunt is always there, because we are having neurosurgery department. They are regularly doing shunt for other reason also. So definitely the chances of infection and revisiting the shunt or re-exploring the shunt or re-putting the shunt, they are always there. But after stenting, the morbidity is shown to be 0.1%. With 0.1%. The studies are there. And with shunt, it is 1%, even in pediatric age group. So it is very much safe. This is how we have discovered over the year. Now we are further exploring, because also we are new to this. For last 3 to 4 years we are doing this. So this is a viable option, a very good option against your LP shunt or any type of VP shunt.
Thank you, Shikha. I think we'll probably move on to the other topics since. Thank you, Vikas. Thank you, Shikha. Wonderful. Any other comments, Murli? You are a panel. Any comments? Any questions?
Yeah, I just had a question regarding the transverse sinus stenting.
So I think we probably would, since we have 5 more talks, maybe we can have
We
it
have
outside.
moved on to trauma, sixth nerve, myasthenia. Interesting cases, of course, we did.
Yeah,
Visual
myasthenia
fields.
also I had a question.
Yes.
That is regarding the anti-LRP4 and the anti-MuSK. So how often do we see them in our practice for pure ocular myasthenia gravis? I have not seen any. I used to do that anti-MuSK, but it adds on a lot to the cost.
Dr.
So I never got any positive result.
Jyoti, would you like to?
So if you're looking at ocular myasthenia gravis, it's primarily the anti-acetylcholine receptor antibodies. This is more for those where they have generalized. So if you're referring the patient to the neurologist for further management and they're looking at a possibility of the generalized, then they look for these. But in ocular, you don't have these. In fact, as I said, more than 10% don't have any of the antibodies positive.
All right. Yeah, Dr. Anita, you wanted some comment?
So maybe they are doing it more than we are doing. These
yeah. So it's
testing
the
for them.
neurologists
Yeah.
that do. So
They are
as I
doing
said,
more.
those which don't have the anti-cholinesterase antibodies can have 5% of
Yeah.
them can have. In fact, we've reported a child who came with only anti-mask antibodies did not have anything positive. So those are the rare cases. But primarily, we won't do that. In our center, we usually refer to the neurologists. We confirm our ocular findings to more or less figure it out, and then they move ahead to rule out any generalized causes of the same. But what we know is that if in 2 years we are not finding any changes in the ocular features, I mean, they are not getting any generalized features, then it's unlikely for it to convert from an ocular to a generalized mass.
Since we don't have time, let's have a final comment from the chair.
For yourself.
The final comments. We are winding it.
Well, final comments is, of course, thank you very much. Just one point regarding myasthenia, which is the symptom of fluctuating diplopia. I think it's important if there's absence of clear fatigue signs, etc., that even if you think it's myasthenia, please follow these patients closely over 2 weeks, especially follow the pupil. Because contrary to what one thinks, fluctuating diplopia can also occur in ocular motor nerve palsies associated with giant cell arteritis as well as aneurysms. So it's good to just follow these people and check the pupils periodically. We had a wonderful set of talks over all these days, and thank you all for attending. And just to remind you, 9th and 10th December, we hope to see all of you in Hyderabad as well. With that, thank you.